The etiopathogenesis is complex. It's not only the genetic factors which are responsible. Along with the genetic, there are environmental factors also which play an important role for it. Now, just brief line about to coming to the diagnosis of the polycystic ovarian disease. We all know and we all follow the Rotterdam criteria 2011. And if two or the three factors are present, like either amenorrhea, oligomenorrhea, hyperandrogenism, hyperandrogenism, or polycystic appearance on ultrasound. So if any two out of these three are present, we take that as the polycystic ovaries disease. This diagnostic criteria, we all face the challenges with it. This certainly criteria leads to overdiagnosis. But then till now, this is the most common accepted criteria for this. So coming to the myths. Now, have I done something wrong to cause polycystic ovaries? As Dr. Sudha ma'am rightly said, these girls comes with their mother or they come on their own, and they are very panicky and they are very hassled that she has polycystic ovaries. They are worried about their long-term effects. They will not be able to conceive and why their periods are so delayed. So the fact is that it is heritable in 70% of the cases. Women whose mother, the incidence in the child would be 20 to 30%. And if the sister is also has polycystic ovary, the girl would have 40 to 50% of chance of PCOS. Uh, uh, and it definitely, there is an interplay of neuroendocrine, hormonal, metabolic, genetic, and environmental factors. So entirely, it is not in the girl's hand to control the PCOS. But yes, it is a modifiable condition. You can, by doing your good diet, physical exercise, which are just the key factors to improve the PCOS. You can regularize your cycles, you can reduce the symptoms of acne, hirsutism, but definitely genetics do play an important role. And the etiopathogenesis, it starts right in the utero, like when the girl is in the womb itself, the process starts. There is a CNS programming, epigenetic changes takes place. Then there comes the adolescent period where there are environmental exposures, exercises, activities, inflammatory factors. During adolescence, girl is being exposed to hormones, and then during the adulthood and the pregnancy, these neuroendocrine factors uh, continue. So again, a myth that ultrasound is a must for ultrasound diagnosis of PCOS. Now, in young adolescent girl, only two factors, that is oligoanovulation and signs of hyperandrogenism. Now, these signs of hyperandrogenism, either it can be acne, either it can be acanthosis, hirsutism, hair loss, or irregular cycles. If these two factors are present, then in a young adolescent girl, the presence of polycystic ovaries on an ultrasound is not must, because in a young adolescent girl, as such, the ovarian reserve is good. The ovarian reserve till 8 years, ultrasound is not recommended as the diagnostic criteria, because in any case you would find the increased number of follicles. And so again, a myth that AMH alone can be used as a marker for PCOS. It is again not. The fact is that AMH levels, it guides us about the ovarian reserve. It guides us that the number of follicles would be good. It gives us idea about the number of, reflects the ovarian reserve. But as such, that if she has, high AMH like 5 or 6, we do get an idea that this could be having a polycystic ovaries. And when we do an ultrasound, we do find. But as such, till now, AMH has not been labeled as the diagnostic criteria to label a girl as PCOS. So it is right now, it is premature to use AMH level as a single test. And AMH concentrations are elevated in obese and non-obese girls with PCOS of comparable and pubertal status. So even this is the good evidence-based recommendations that serum AMH level should not be used as an alternative for detection of PCOM or a single test for the diagnosis of PCOS. Again, a myth that PCOS only affects the overweight women. No doubt about it that obesity and PCO are interlinked. Obesity can make the PCOS symptoms worse. 38 to 88% of the PCOS, either they are overweight or obese. It's not only that, we do see up to 30% of the women with PCOS, they are thin and lean. And for lean women with PCOS, the prevalence of insulin resistance is also again high. And lean women with PCOS often go unnoticed for years. So it is like, the chicken and the egg, like PCOS is there is insulin resistance, she gains weight, then again, it is a diagnostic of PCOS. So they all are basically interrelated. So, it is not to be taken like this that PCOS occurs only in overweight or obese women. PCOS do affect the young, thin, lean girls also. And overweight, the only thing is that it is diagnosed little early in the overweight girls, because usually the presentation, because of the insulin resistance, the presentation would be that they would present with irregular periods early. Thin lean women, they may not be diagnosed early because till the time they find it difficult to conceive. And increased level of androgens like male hormones, acne, unwanted hair growth, they are more common in thin lean PCOS girls. Again, a myth that measuring serum insulin is a must to diagnose PCOS. All my slides, I have highlighted that insulin resistance is a common feature of polycystic ovarian syndrome. But yes, that again, the insulin resistance leads to hyperinsulinemia, which plays an important role in body's increased androgen production and hence obesity. So for especially for the Indian population or for the Asian population, we do take these criteria as suggestive of insulin resistance, like waist hip ratio more than 0.85, acanthosis nigricans, hyperandrogenism. Now, acanthosis nigricans is just the brown velvety hyperpigmented spots at the nape of the neck. But the current definitions and recommendations and guidelines do not include insulin resistance or hyperinsulinemia as a diagnostic feature. Because, we see a lot of prescriptions, even we have the habit of writing these tests, like we do write serum insulin levels and the blood sugar levels, we do write fasting and do it PP. But as such, these guidelines, they do not favor measuring the serum insulin levels. The clinical signs and symptoms are suggestive of insulin resistance, and we can avoid doing these tests. Now, these are the ESHRE recommendations from the International Evidence-Based Guidelines for the Assessment and Management of Polycystic Ovarian Disease by Teddy et al. And they recommend that 75 grams oral glucose tolerance test is recommended to assess the glycemic status. BMI more than 25 or in Asians more than 23. If there is a history of impaired fasting glucose, impaired glucose tolerance, diabetes, or if there is a family history of diabetes or hypertension, then all these tests like 75 grams glucose should be offered in all women preconceptionally to avoid the increased risk of hyperglycemia or gestational diabetes, which might occur during pregnancy. Again, a myth that if your menstrual cycles are irregular, you're bound to have PCOS. Again, it's not true. The fact is that normal cycle length is 21 to 35 days. But there are other causes for irregular cycles also, like thyroid disease, if she's breastfeeding, if there is a hyperprolactinemia, or if she's extreme dieting or over exercising, if there is a stress. These days we see a lot of girls working in MNCs, they have a lot of pressure and they come that their periods are delayed. Then other organic causes could be Cushing syndrome, late onset congenital adrenal hyperplasia. Then there could be pelvic inflammatory disease, uterine fibroids and polyps. So the lesson is, and the fact is that all irregular cycles are not PCOS. We need to be high alert on that, that a young girl could be having PCOS, but then a good detailed history is must, and we have to rule out other causes before we jump to diagnosing her as PCOS. All acne are because of PCOS. I guess all my colleagues will agree with me that we do get a lot of referrals from our dermatologist friends because they also want to be sure that PCOS is not the cause for the acne. Now, there is a difference, the acne which are being presented by the PCOS girls and the acne which are present of the acne vulgaris. We know that acne is a sign of hyperandrogenism. The acne alone in PCOS girls is prevalent in 20 to 40% of the cases and hirsutism in 40 to 80% of the cases. Now, coming to the differences, in PCOS acne, there is a hyperandrogenism, menstrual irregularities, and insulin resistance, signs of like we'll find acanthosis nigricans and alopecia bandness. This acne of PCOS, it will not respond to the conventional therapy. When we do the blood test, there would be elevated levels of DHEAS, DHT, androstenedione, testosterone, and insulin growth factors. Now, this just to diagrammatically represent this PCOS acne, it tends to occur more along the jawline, chin, and upper neck. Now, acne vulgaris in young adolescent girls, we do find very high incidence of acne in adolescent girls, and but majority of them they remit before 30 years of life. And the difference between the acne and PCOS and the acne vulgaris is that the androgen levels are usually normal in acne vulgaris, and this is the kind of presentation that is there in the acne vulgaris vis-a-vis acne in PCOS, which is mostly restricted to the jawline, and these are usually present over the entire face. However, it becomes very difficult. This is just the theoretical part of it, but when we see practically, at times it becomes difficult to distinguish between the two acne. Coming to alopecia also, we do see girls coming, oh ma'am bahut hair fall ho raha hai, itna itna guchha nikal raha hai when we comb our hair. So even alopecia is very common in PCOS. Now in PCOS alopecia, there is a thinning at the vertex. You can make out like there would be from this side and from the this side there would be alopecia, and the hair would be thin, and then there would be bitemporal recession also. Whereas the non PCOS alopecia, there is a loss of hair in the central region of the scalp. This you would find, at the head, the most prominent portion of the head, there would be baldness and there would be loss of hair, or along the scalp on the main head. Again, this thing that, so मेरा वो ऊपर मिथ छुप गया है उसमें. So I think it is just related to that if you're PCOS, you cannot conceive. So the fact is that we agree that PCOS is the causes anovulation and represents 80% of the anovulatory infertility cases, but 30% of the women, they still ovulate intermittently. And the principal infertility treatment includes the lifestyle changes. Ovulation, there are simple ovulation induction drugs. First line, we know clomiphene, letrozole being taken as the first line, especially for the PCOS patient. No response, gonadotropins, add metformin, or do ovarian drilling if you are taking her for another reason for laparoscopy. And if still no response, then IVF works as a third line. So, this counseling is very, very important. These girls, whenever they are coming, either with the mother and when they are not married, or either they are coming with the husbands when they are trying to conceive and they are not able to conceive, it's just simple. The first line of management that holds true for PCOS is that they have to lose weight. Even if they lose weight, and even if they lose weight, the cycles become regular. They start spontaneous ovulation in as high as 30 to 40% of the cases, even if they lose 6 to 8% of the body weight. So that is very, very important. Counseling is very important. The lifestyle factors, lose weight, less of sugars, less of junk food, I think that really helps in conception. Again, if you're not looking to get pregnant, you don't have to worry about the PCOS. No, it's actually a metabolic syndrome. There are long term implications. The girl is at a risk of cardiovascular disease, hepatic steatosis, glucose intolerance, diabetes, dyslipidemia, and hypertension later on in life, and along with the sleep disorders, depression, anxiety. These girls at times they are on antidepressants these days also, because there's so much of stress they take it a lot. Of course there are other reasons to take the stress, but yes, the incidence of stress and depression is high in these girls. And then there are other endocrine disorders. So I'll just quickly finish it up, one or two more myths. So if you're not, these pills again a myth, that long term, to prevent the long term hazards, healthy lifestyle, I have highlighted this slide already, that what is the importance of the lifestyle, lifestyle modification. Now, coming to the treatment, that how long, if a young adolescent girl is coming to you, then how long you can give the treatment. So, in young adolescent girls with PCOS, treatment beyond 24 months, that means 2 years, is usually not recommended. But yes, these birth control pills can be given safely to the married couples who, as it is, they are planning to delay their fertility, or they're wanting as a contraception. But yes, if the girl is looking only for the irregular menstrual irregularity, then probably we don't need to give estrogens, because of the insulin resistance, high LH. These girls usually have high estrogens level, so we just can give Meprate, medroxyprogesterone, 10 milligram twice daily for 5 days, the standard protocol that we all follow from day 21. And diane somehow is not to be preferred, because the progesterone in that is because the estrogen and the progesterone component, like ethinyl estradiol and the cyproterone acetate, there is an increased risk of venous embolism. And coming to the metformin, again, a very, very important topic, because we all tend to override metformin. But however, the international guidelines for PCOS, they say metformin is to be used when a girl is either obese, she is at a risk of high metabolic risk, like there is a history of diabetes or impaired glucose tolerance or high risk ethnic group. Then you start at the low dose with 500 milligram. Do not straight away jump to such high dose. The dose usually could be 1500 to 1700 milligram. And if you find that there is a, you have given the ovulation induction drug like clomiphene, she is resistant, then you can add metformin to reduce the clomiphene resistance, especially if a girl is obese. Probiotics, I will just skip. This is a new topic in the research settings, which is coming up, that that probiotics, they help in PCOS. So the one line I would just say about it, that till now, no data is conclusive about that, because a lot of prescriptions we see with the probiotics coming up these days. So with this, I think I wind up my talk. And I request Sudha ma'am and Shashi ma'am to give their expert comment.
Very well done, Shalini. You have
Thank you
really
so much,
covered
ma'am.
all the myth and the solution of all these problem. It is a very enlightening for every audience who are hearing this, because in the level of adolescent, during the reproductive age group, during menopause, you should have touched, means all are having problem and metabolic disorder can happen. So it is not just a polycystic ovarian syndrome, it covers in all life, and it has to be we have to give solution, we have to counsel them properly to for all these problems. And AMH, I just want to say one word about the AMH. We are doing lots of AMH to find out that PCO hai ki nahi hai. No, it's not that. AMH also giving the wrong impression. In
Yes.
adolescent, it is recommended. PCOS guideline has come in 2023, and it
Mhm.
said the AMH should not be done, because if you have seen that there is a menstrual irregularity and the hyperandrogenism is there, that means she is PCO, definitely. So we have to correct, we have to encourage the child for the lifestyle modification. So you have done very well, good justice to the topic. I was also thinking that how much you will be able to cover in a short time, but even though the problem was there with the digital media, but even though you have covered very well, Shalini, congratulations. Thank you.
Thank you so much, ma'am, for your kind words. Shashibala, ma'am.
Congratulations, Dr. Shalini. We know that this social media, this is the double-edged sword. So we have all experienced this. And despite of such a hustle, Dr. Shalini has taken it as a this thing very strongly and concluded the topic. And one word I want to add here, that in adolescence, as Madam Sudha has said, in 2023, there is different guidelines for diagnosing the adolescent girls as a PCO, because every girl is getting a ultrasound in their hands and they are
Yeah.
coming up and they are eating our head actually. So we have to be little patient with these girls, with their parents, that they need lots of counseling and less of the treatment. So that is all from my side. The topic has been covered very beautifully. Thank you, everyone. Thank you for giving me this opportunity.
Thank you so much, Dr. Shashi, for your kind words. I think because of all this, my the slides for the faculty is, I don't know, I can't trace it. So my pleasure.
Don't
I would
worry.
just read their CVs like
You
that.
are doing wonderfully. Don't
Want
worry
to
for
ask
that.
you, Dr. Shalini, you said for
Yeah.
adolescent girls,
Yeah.
dye you should not give for more than 2 years. But what about drospirenone combination, Yasmin combination? Can that be given for longer time?
No, Dr. Anshu, yeah, that is what I highlighted. In fact, that was actually an eye opener for me because, we to the young girls seeing a
Yeah.
little bit of acne, we start giving them Dine 35 and all
Yeah.
those girls, Yasmin and all those things. But when I read this RCOG guidelines or these ESHRE guidelines, they say it is not to be given just the simple, these birth control pills, contraceptive pills like Novelon, Femelon, they can be given because with the diene composition, there is certainly an increased risk of thromboembolism. So post I read that, I have stopped giving diene
Okay,
to
what about
the.
Yasmin, drospirenone? I'm asking for Yasmin. What about that combination? That also similar risk of DVT.
Drospirenone, I mean, it is actually a much safer as compared to the diene. So
Doesn't lead
this
to
can
weight
be given,
loss.
yes, because drospirenone is not that androgenic, so it
Drospirenone
can be given.
can be given.
Yeah,
The
I want-
yeah.
guideline says the COC is the better one, is the first line of drugs for this.
Yes, yes, ma'am. Yes. So with this, we quickly go on to the next session. And my pleasure to invite Professor Namita Agarwal. Warm welcome, ma'am. Professor Namita Agarwal, ma'am, is the professor at SRMS IMS Bareilly, UP, India. And her special areas of interest are high-risk pregnancy, infertility, and endogyne surgery. She has a lot of achievements. She runs this Foxy certified course in endoscopy gynecology. She has participated as a faculty and has more than 15 publications. Welcome, Namita ma'am. Dr. Rupali, warm welcome. Dr. Rupali is a very dear friend. She's very humble, always helpful. She is the coordinator and senior consultant in reproductive medicine at Indraprasth Apollo Hospital, and she holds very good positions. She's actually the she's the editor of the Fertility and Science Research Journal, and she's also the was also the web editor of Indian Fertility Society 20 to 2022. Warm welcome, Rupali. My pleasure to invite Dr. Ruchika Goel. Dr. Ruchika is the consultant IVF at Sri Ram Murthy Samarak Institute of Medical Science, Bareilly, and she has undergone special training in IVF in 2015. She has huge number of publications, and she's currently the treasurer of Western chapter of Indian Fertility Society. So pleasure to all the chairpersons. My pleasure to invite Dr. Ritu Jain, who would be talking now. Dr. Ritu Jain, again, a very humble and a dear friend. She is the director of Vardhaman Medicare IVF Center. She's also the president of Gurgaon Obs and Gynae Society. Along with me, she's the co-convener for this SIG. Lot many awards, lot many positions held. So over to Dr. Ritu for your talk.
Thank you, Dr. Shalini. So I would like to share my screen.
Yeah.
Good evening, everyone. I am not able to share. Something is
You're not able to share. I think I have stopped sharing.
okay. I'll try again.
Yeah.
No,
Just click on the share screen.
I did. I'm not getting my this thing on this, no? I'm not getting my screen over there.
You're not getting me. Himanshu, मेरी तो screen नहीं share हो रही ना?
No, ma'am.
मैंने तो
मेरा
stop.
नहीं दिखा रहा है.
हम आपने पीपीटी खोला हुआ है मैम?
खोला नहीं हुआ, but it is there. मैं खोल देती हूँ.
यस मैम, एक बार
हाँ, वो खोल के आ जाएगा.
यस मैम.
Okay.
Minimize करके रखो computer screen पे and then.
अभी आया? Is it
नहीं.
visible?
नो मैम.
Huh?
Oh, you
No.
will have to share click on that then.
No,
हाँ.
I did. 1 minute, I'll do it again.
Yeah.
Shalini, I'm seeing your picture
Hmm.
and I'm seeing the screen. I don't know. 1 minute. It is. It is always easy. Why it is not happening now?
मैं exit करती हूँ कहीं ऐसा ना हो कि मेरा
Is
हो
it?
रहा हो.
नहीं, Shalini, don't exit. I'll do it again. I am not able to get the screen as share screen. Huh?
नहीं, वो नीचे आएगा ना.
हाँ, आता तो है नीचे, but it is not coming. Wait.
नहीं तो जल्दी से
अभी
हिमांशु को.
एक मिनट. I think now I'm getting.
Okay, great.
Is it visible?
Yes, yes.
Pranam.
Slide share पे डाल दो.
Yeah. Sorry for delay. Slide
No
share.
worries. Today we are all struggling.
Yeah. Where is slide share पे भी आएगा तो I am okay with this. Otherwise I can.
नहीं नहीं आ रहा है कर आ
Slide.
जाएगा.
Yeah. So sorry everyone for the delay. So well, my topic is little different because it is little different because it deals not only with PCOS, it is dealing with all the aspects of infertility and the common things which are happening and we are simply ignoring. The lifestyle is lifestyle is affecting the bringing of life itself. The way we eat, we drink, we breathe, and our sleep patterns, everything is affecting the new origins, that is the life. So the focus today is on the common things like the coital practices, sleep pattern, diet, obesity, exercise, age, habits, stress, and electromagnetic radiations. We are all surrounded with it. So if we ask a new couple who has come to our office for fertility, that what is the fertile window, they will often say ki, okay, we use that ovulation kit according to the calendar. They say they take their mobile and they say, okay, these are the only days we are doing. So 33% of the people are not even aware of what fertile window is, and they are not even aware that fecundity is 10%. And they often check in LH kit and sometimes they miss because that comes positive, 2 lines come positive for 5 days and they are under stress to have relations in those days, intercourse. So it is very important for them to have an awareness that once the period is over, 1 or 2 days after that, they can have daily or alternate day, whichever they prefer. And there is no difference in the outcome. There are studies to show that. The other thing they often ask is that should they remain supine or should they lie down for a few minutes, 5 minutes? There is no evidence to say that getting up immediately reduces the fertility rate. Sometimes they experience problem like they need some lubrication. So KY products and saliva is absolutely not to be recommended. For initial starting or ejaculatory dysfunction, sometimes baby oil or canola oil or hydroxyethyl cellulase based lubricant can be suggested. So they have to be made aware of the correct coital practices. Then sleep pattern and reproductive health. It is so important that our sleep is affecting our melatonin levels and it is affecting the ovulation process itself. And then decreased sleep and overnight working in these companies, sometimes the HPO axis is completely disturbed, and disturbed circadian rhythm is also one of the causative factors in PCOS, menstrual irregularities, increased stress leading to endometriosis. The husband and wife, they are working at different time. One is working in day shift and other is working in night shift, so they hardly have any time to have time together. So this definitely leads to increased problems in conception. So with this, they are also not aware that diminished ovarian reserve is also a component of disturbed sleep. So HPO excess activation is the main factor for proper ovulation, and sleep dysregulation disturbs the circadian rhythm, and it definitely affects the reproductive organ anatomy and uterine receptivity. It either suppresses or augments the reproductive hormones, and of course melatonin is decreased and inflammatory response is increased. We know that all these hormones have their patterns, like if we take prolactin, it is peaking at the later part of the sleep and it is minimum in the morning. TSH, we know it is minimal at 10 a.m. and it peaks at midnight. LH has variations. These all are pulsatile hormones, and LH pulsatility is changed according to the changed sleep pattern. And testosterone, it starts increasing post sleep and it peaks in the morning. This is a normal variation. So when sleep is disturbed, it leads to insomnia, and neuroendocrine disturbs leads to changes in the hormonal pattern, that is chronic activation of the HPO axis, increased ACTH, cortisol, GnRH, LH and FSH, they are all disturbed. So what actually happens with sleep disturbance? The TSH levels are increased, which leads to anovulation and miscarriages. LH is increased. FSH is also increased, which leads to poor ovarian reserve, as I showed in the previous slide. Prolactin is increased, which again leads to anovulation, PCOS, and endometriosis. Androgens increase, it leads to PCOS. Estradiol hormone is changed. AMH, of course, is decreased, and progesterone levels are decreased, leading to decreased implantation. So definitely melatonin is disturbed by the disturbed sleep cycle. And we know the important role of melatonin as oocyte maturation. It is an apoptotic, as it by enhancement of endogenous glutathione levels, it protects against the mitochondrial injury in the granulosa cells, and it enhances DNA methylation reprogramming. So it is a very important component which is linked to the sleep. So now coming on to the diet. There are certain diet which really fades the fertility, and the real culprits are the simple or refined carbohydrates, trans fats, highly processed food, alcohol, excessive caffeine intake, more than 500 milligram per day, as person is working and they keep drinking to keep themselves active, and keep eating the junk food. So this is the pattern of diet: pizza, momo, burger, and cold drinks. So they are all are high energy drinks with disrupting the endocrine system. They are xenoestrogens, and increased level of testosterone definitely have effect on the essential developmental regulatory genes. These are obesogenic and they disrupt the metabolic and endocrine activities, especially BPAs and other. So consumption of carbonated beverages is also associated with increased concentration of estradiol. In short, if I say that all the hormonal pattern is disturbed, in fact, it disturbs the in fact, obesity disturbs the follicular fluid levels of oleic acid. The embryo fragmentation is increased. There is increased concentration of stearic acid, again leading to poor blastomere score. It has been shown that leptin-rich diet, it leads to impaired folliculogenesis as well as decreased rate of ovulation and it inhibits the estradiol production by the granulosa cells, which are LH driven. So there is faster rate of apoptosis in granulosa cell. This was a very good study published in January 23 from India by Divya Gautam and all. This is a FIGO literature review, obesity and infertility. And WHO definitely recommends that the consumption of TFAs, trans fatty acid, should be reduced. It should be only less than 1% of total energy intake. So the kind of junk food people eat nowadays has more than 20% of TFAs. So what TFAs lead to? It leads to insulin resistance, PCOS, endometriosis, and it activates the gamma receptors. So it is a sort of a vicious cycle. The kind of food which is eaten nowadays, it leads to PCOS and endometriosis. So what should be taken in as a sort of uh, response to this? What is recommended is omega-3 fatty acid, which has a contradictory effect. It has a promotive effect on the growth and maturation of oocytes. It definitely improves the embryo morphology, and it improves the implantation also, and it decreases the FSH. So omega-3 fatty acid should be taken more, and trans fatty acid should be reduced. So what are the healthy fats one should eat? It is like fish, nuts like almond, walnut, macadamia nuts, hazelnuts, seeds, chia seed, flax seed, pumpkin seed, olive oil or avocado avocado oils. In fact, the butter or that should be replaced by avocado. So the healthy diet should be like protein rich. The sources like tofu, microproteins, seafood rich, which is rich in omega-3 fatty acid, whole grains like oatmeal, brown rice, rye, whole wheat, that should be taken, raw nuts as a top up, and legumes, all the legumes, especially the chickpeas, black beans, and the red beans. So the diet which should be taken is low in TFAs and higher consumption of mono and polyunsaturated fatty acid. The diet preferred for fertility is a high plant protein rich diet, and consumption of animal protein should be decreased. A low glycemic index, high fiber food diet is suggested. So to promote the fertility, the diet which is recommended is Mediterranean or protein-based diet. What is Mediterranean diet? We know it is rich in mufas and pufas, and healthy seafood consumption, dairy consumption is high in these, whole grain, mostly fresh vegetables, low consumption of sweets. And what effect has on fertility? It increases the chances of fertilization, and it definitely supports our ART procedures also. Whereas the Western style diet, which is rich in trans fatty acids and animal protein is more, refined cereals are more, low intake on fresh fruits, it has indirect effect on the fertility. It increases insulin resistance, type 2 diabetes, and impairs the ovulation, ART procedures also. So they are interlinked, the diet, PCOS, and endometriosis. A healthy diet is a prerequisite to prevent PCOS and endometriosis. Now, it's not only the macronutrients which affect the fertility, it is the micronutrients also. And there are certain micronutrients which are very, very essential for fertility. For male, like selenium, zinc, vitamins E, C, and beta carotene and folate, because it is the the nuclear and the cytoplasm reconstruction sort of a factory. It is the male and female cellular level function should be absolutely in phase. Even a deficiency of B12 will also decrease stop the process of fertilization. So homocysteine, if it is increased, this will also stop the process of embryo formation. And for female, folate, zinc, vitamin C, B12, D, and vitamin A. So there is a definite impact of preconception micronutrition on female fertility, and every single element matters. Of course, age, we all know this Poseidon criteria. There is a huge difference in the response in group 1, 2, 3, and 4. The couples who are working in IT, or as the marriages are happening late and late, so knowingly or unknowingly, they are shifting themselves from group 1 to group 4, where the ovarian reserve were already decreased, and to get one blastocyst we need at least 18 to get one pregnancy we need at least 18 blastocyst in group 4. So the couple doesn't come to know only to choose a partner, and to settle with the partner pulls them from group 1 to group 4. So age we know is the biggest biomarker, and it affects the fertility like anything. At 40, even with IVF, the conception is very low with their own egg. So age increases, fertility decreases, and miscarriage and aneuploidy increase. It is because of the because age affects the every process of fertilization. It affects the oocyte as well as the sperm by causing aneuploidies, altering the methylation process, increasing the levels of histone, causing more fragmented embryos, and ultimately the decreased fertilization and implantation rate. We all are surrounded by the electromagnetic radiation, more so the younger generation. They are unaware that radio frequency electromagnetic waves have deleterious effect on the sperm parameters, the count, morphology, motility. It affects the cellular metabolism, endocrine system, and it is genotoxic. It leads to increased oxidative stress and genomic instability. Here also, melatonin, N-acetylcysteine, green tea, medicinal plant leaf, they have their antioxidant property, and they can counteract the effect of electromagnetic radiation. But the best way is to avoid, minimize their use. We cannot avoid in today's world. And the damage is, in fact, a study in Cleveland Clinic has shown it is exposure dependent manner. The difference in the hours of the cell phone user have shown the significant impact on the sperm parameters in 2 sperm groups. This was a study, the use restricted to less than 4 hours or less than 2 hours or more than 2 hours, and it affected the sperm parameter. So the most common effect is from the cell phone and the laptop. These are the one which we are using and we know about it. But the one which we are not seeing, like your wireless radio, TV broadcast, and all the gadgets in the kitchen and in the bedroom, they all have effect on the steroidogenesis, on the Leydig cell Sertoli system, and the semen parameters are affected adversely. Not only the semen parameters, even the oocyte quality and the fertilization is affected, because all these ultimately leads to DNA damage. So what can be done to it? All leads to increased stress. What can be done to manage it is the time management, the proper use of these gadgets, the time for proper time for exercise, because that rejuvenates the whole system, to have the proper diet. Some meditation and yoga has to be done, music and de-stressors, some therapies which can help. And more important is, like the Indian traditional system, yoga and exercise, walk for 15 minutes. Even all the national and international bodies have recommended exercise as the first treatment in PCOS. Dr. Rajvi will probably take up more on yoga and exercise. Thank you so much. So, in fact, the small little things which are being ignored contribute to major extent as the cause of infertility. If they are taken care and well in time, probably a lot will be. There is somebody else. Hello.
Hello, yeah, Dr. Ritu.
There is somebody else has entered wrongly. You saw that pic. Somebody else has entered wrongly in our this.
अब तो नहीं दिखा, वो उस टाइम पे था, मेरे टाइम
नहीं,
पे सारा
अभी भी था डॉक्टर
अभी भी
I
था.
saw that too.
There was somebody, because the problem is not this, problem is ki they can, later on. So you just ask Himanshu to look at this again.
या हिमांशु एडमिन राइट्स नहीं देना है किसी को, सिर्फ
No,
हमें
no.
फैकल्टी मेंबर्स को देना है.
There was some male wearing goggles and probably
That was a picture actually. That was not a somebody live. They had put a picture.
Ma'am, I
Okay.
have removed
Live,
him.
अच्छा,
oh,
ठीक ठीक
so the live picture.
Yeah.
okay.
So
So
I'm open to any question and answers.
thanks, Dr. Ritu. It was such a comprehensive talk, very well covered all aspects, male, female. And I would request the experts for this session, Dr. Namita, Dr. Rupali, Dr. Ruchika, to begin. Dr. Namita.
Everyone. First of all, I would like to congratulate the organizers for choosing such a pertinent topic, which is around us, all around us. Number two, Dr. Ritu Jain has covered each and everything beautifully. It was really a pleasure listening to you, Dr. Ritu.
Thank you.
One thing we would like to say is that it is a vicious cycle. And this vicious cycle, the first and the primary treatment we all know is lifestyle management, which has to be done in a very comprehensive and smart manner. It has to be achievable, realistic, and what has the specific things which you touched were really very, very important and pertinent to what really needs to be done with PCOS at all age groups, starting from lean as well as obese ones, starting from adolescent to the elderly. Thank you, Dr. Thank you.
Thank you, Dr.
Thank you.
Namita. Yeah, Dr. Rupali.
I would really like to congratulate the entire team as well as Dr. Ritu for such a wonderfully covered topic. Just to add on, as of now, especially with the upcoming corporate lifestyle, with the way people are living, a lot of use of disposables, plastics containing BPA is also there, which is really creating an epidemic, when you talk of decreased ovarian function, when you talk of poor male function, and of course to talk about AQI, which is really deteriorating nowadays, which is actually the
Yeah.
hot topic.
That's
Which,
actually adding fuel
you
to
know,
the fire.
absolutely leading to
Yeah.
such huge problems. But yes, very well covered. Other than that, I think everything has been talked about. Yeah.
Great. Dr.
Thank
Ruchika. Thanks, Rupali. Dr. Ruchika, are you there?
Yeah, ma'am. Thank you so much. And on behalf of Western UP IFS chapter, I would also like to thank you for making us part of this interest covered by the speaker and all the experts. Rightly, it is said that lifestyle has created this illness, and change in lifestyle will again go a long way to correct it. Also,
Yeah,
Yeah.
true, ma'am. Thank you.
Very,
thank
very
you.
good.
Thank you.
Any questions from the audience?
How
Okay,
many
that's
hours of mobile usage do you recommend to your patient? How many hours? If you have to simplify it and tell it to your patient, Dr. Ritu.
Yeah, I tell them to minimize, just see and keep it on the table. I don't.
You
I am
can't quantify.
very
Keep away from it. Especially while
Yeah.
sleeping nowadays, people are very
One thing I
tell them
always
to
tell
Yes.
my
cycle.
patients to switch off the Wi-Fi when they sleep, because if the phone is there, Wi-Fi is there, and we know Siri and all, they are active all the time, even if we have switched it off. So they are sort of in a electromagnetic circle. So the Wi-Fi at the time of sleep should be kept off, because that time you are not doing any conference or not doing any work which needs, internet system. So if it is switched off
Right.
that time also, 6 hours to 8 hours at least, you are free from that Wi-Fi circuit.
That's good.
And
Rightly
especially,
said.
for the males, like we do say, do not keep the phone in their jeans pocket or the back pockets, because then the gonads are directly in contact with the electromagnetic radiations. And
And
it
the
is
heat also.
recommended, it is
Hmm.
recommended not as a fertility, but for the overall general health also, that talk on speakers so that the phone is not
Yes.
close to your ears. And definitely to avoid the usage of these AirPods, and that has been rampant. We all use so much, so that is also to be avoided. For the overall
And the
health.
screen light also
Yeah.
should be on the minimum required for vision.
Yes, yes. Very
It's
well
an
covered.
endless topic. We can
Yeah.
cover on it for like 1 hour also, minimize the things for the talk.
Yeah, yeah. Okay. Thank you so much, all the speakers and the chairpersons for this session. And now my pleasure to invite Dr. Mridu Sinha. Dr. Mridu Sinha, ma'am, is the professor at SRMS IMS Bareilly, and ma'am has been awarded the fellowships in minimal access surgery by World Association of Laparoscopic Surgeons in June 2014. She underwent IVF training by Foxy Register Training Center, New Delhi in 2015. Lot of research, lot of publications, lot of papers, and ma'am is a great teacher. And I'm sure all her students must be very happy to have her. And my pleasure to invite Dr. Anshu Jindal also. Dr. Anshu Jindal, ma'am, it is just taking a time to open up your CV. But yes, as far as I know, ma'am is a leading IVF practitioner at Meerut. Both of them, Dr. Sunil Jindal and Dr. Anshu Jindal, they are doing a fabulous and a fantastic job. Always a pleasure and to listen and to see their YouTube videos. And I guess they both are great academicians, must be huge numbers of books, publications, etc. So warm welcome to Dr. Anshu.
Thank you.
My pleasure to invite Dr. Rajvi Mehta. I've introduced Rajvi ma'am, but yes, just to say, ma'am is a great orator and is a great presentations. It would be a pleasure to listen to this talk by Dr. Rajvi. Over to Dr. Rajvi.
Thank you, Dr. Shalini. And as the convener of the IFS Holistic Medicine, I also thank the Western UP chapter for joining hands with us. So directly, I'm going to be talking about, we talked about lifestyle, we talked about stress, and then we come to our ancient Indian science, whether yoga has any role in de-stressing.
Maharaj.
So in general, we tend to feel that yes, yoga is well known to be a de-stressing agent. But when we are talking in a scientific forum, we also want to know the evidence. We also want to know what to do. So first and foremost, when we talk, and very often, when we don't have a real answer to a problem, we sort of blame it on stress because it's the easiest to blame, and we all believe that our generation is the most stressed, and generations to come have a lot of stress to handle, and that is the cause for many of the disorders, not just PCO. So talking about the actual evidence and talking about things here, this is a paper published just a little earlier this year, and it has come from Chennai, where they talked about a real link between PCOS and stress. Because otherwise it's a very it's not even a cause and effect kind of relationship. It is often not an association, it is a presumption. So in this particular paper, they did show that the serum levels of cortisol and DHEA is of course well known, significantly elevated in PCOS compared to healthy women. And cortisol being a very big marker of stress, it clearly indicated the role of possible association between stress and PCOS. And the other studies that have been published a couple of years ago have really shown that the stress hormone levels were significantly, distinctly higher between women with PCOS and those who did not have a PCOS. And therefore, stress could possibly play a very silent role in the pathogenesis of PCOS. Now, having said that, one really wants to know that what possibly could be a mechanism. And although we still don't have any kind of publications giving us the detailed mechanisms or how stress really affects PCOS, but here I would like to draw your attention to notes by Dr. Subhash Mukherjee. Now, Dr. Subhash Mukherjee was the one responsible for the first IVF in India and the first to have a IVF birth after a frozen embryo transfer way back in 78. And although the historical perspectives are quite saddening because he was put through investigations and his work was not allowed to be published or sent abroad to present his work, he ultimately committed suicide in 1981. However, after 15 years, we got hold of his notes. And interestingly, he talked about entire possible pathogenesis of how stress affects PCOS. So I've just given a screenshot of something which was thought of at a time when PCOS was not something that worried clinicians or patients at that point of time. So these are the notes from 1970. Now, exactly when we talk of stress, everybody's understanding of stress is different. I mean, each of us feels that we are the ones who are most stressed. I work very hard. I have long hours, and I have a lot of pressure. So, how do you really define stress? And one says that a stress is actually a state of mental or emotional strain or tension resulting from adverse and demanding circumstances. Now, the word here is demanding because what can be demanding for you may not be demanding for me or vice versa. So, each of us sees stress differently. So actually, it is not stress, but it is the perception of stress which is varying. And if we are not able, we are not capable, or we are not prepared, or we are not trained, then we start perceiving everything as stress. So somebody who is very well in the proficient in their jobs may not feel the stress. Now, specifically in infertility and more specifically in PCOS, the first is the physiological cause. Then imagine a young girl with hirsutism at an age where you're very conscious of your appearance. Hirsutism is definitely something which is going to add stress to the young girl. Irregular period talks about a future where they're really worried whether there's something wrong, and they don't really want to talk about it to their family members. So that adds on to the stress. Then metabolic changes are a physiological cause for stress. Weight gain, again, although there is much more awareness about body shaming today amongst the youth, but still, the moment a girl gains weight, there is questions, people look at people pass comments, and all this adds on stress. And then whenever they visit a doctor or a clinician, they're asked to lose weight. And that stresses them further because they don't know how to lose weight. And generally, if you talk to any person, they'll say, I don't really eat much. You're asking to make dietary changes, but I don't really eat much. So it is going like in a circular manner, and then it sort of the cycle just continues and one doesn't know how to break it. So we are therefore trying to use an approach, say like yoga, where you don't have to tell them anything, you get them to do it and hope that it breaks this cycle. So basically, endocrine disruption leads to weight gain leads to endocrine disruption, and the cycle goes on, and the stress keeps adding on. So having said that, I just want to talk about specific symptoms of stress. That when a person is stressed, they feel, stress in the body, they feel trembling in the body. When you're stressed, you feel your mouth is drying up. You'll say, I'm very tensed, my skin hair is standing up, a kind of burning. There's a lot of sense of stress leading to, bordering on depression. And it's, you're overwhelmed with pity, sorrow, and, agitated. So you don't have an emotional control or equanimity to say, are these the symptoms of stress? And most of the times we'll agree. But I just would like to say that all that I have listed here is not something which has been said in the last 10, 15, 20 years or even 100 years. These are, put it in a different language, these are quotes from the Bhagavad Gita, where Arjuna is among tremendous stress trying to decide whether he should be fighting his cousins. So basically to say stress is not something which is new to this generation or to this millennia. Stress has always existed. What has changed is our perception of stress, our ability to handle stress, and this is possibly making a difference. So having said that, coming back to our topic of discussion, I'm talking of yoga, and can yoga play a role in de-stressing or improving our ability to handle stress, or we don't perceive stress. So if we don't perceive stress, we are not stressed and we don't have symptoms of stress. And it's a very ancient science, goes back to 2.5 millennia. It's supposed to be dated nearly 2nd to 5th century BC. And it's mainly a science of the mind and consciousness. So if a science of the mind definitely will help to handle the mind itself, which is into the state of stress. So again, we're talking in a scientific forum. We're not talking to a general public who is interested what knows yoga is. So if you want to delve into anything new, you either need to have experience or you need evidence to show whether it really works. Otherwise, one can talk on an individual basis, but if you're talking in a scientific forum, you want evidence. So what does the evidence say is the key to de-stress in yoga? And it's an interesting study did many years ago, because when it comes to yoga, there is always a kind of tussle between the yogic practitioners and the scientific. The yogic practitioners believe that the science is much older than modern medicine. We go back a long way. The fact that it has survived 2000 years, why do we need to prove anything? And the scientific practitioners will say, well, you're claiming to have something which is effective, then please show us the evidence. It's not just sufficient to start advising people to do it, especially in a larger scale, unless we see evidence that it really works. So only then can it become the first line of treatment. Otherwise, when everything else fails, you'll say, okay, go and try yoga. If it helps you, fine. So having said that, the study was done by a German group, and they saw that they studied the perception of emotional stress and a control waitlisted group and a yoga group. And what is very important here, that the waitlisted group was a control group. Otherwise, the question always arises that those who already believed in yoga are going to benefit from it. But here were a group of people who wanted to do yoga, but were put in to do it later. So their mindset was pretty similar. And within 3 months, the assessments were done using the standard scales of assessing anxiety, depression, and stress. They found a decrease in perceived stress, decrease in state and trait anxiety, decreased depression, and along with a reduction in stress, there is more energy, so decreased fatigue, and correspondingly increased vigor and well-being. And subsequently, there have been many more studies which have clearly demonstrated that yoga plays a role in that stress. And then when you looked at perceived stress, another study done in 2012, wherein they clearly showed that if you look at the yoga, 2 different yoga groups, over a baseline and over a period of 3 months, again, there is a clear-cut reduction in the perceived stress level scores, and it were 2 different groups. So even when the control group, later waitlisted control, actually participated in the yoga practices, there was a difference. And it's highly significant, showing that the effects show within 3 months of practice. Also in young adults, because we are talking of PCOS, we are talking of young women, and who possibly have hirsutism, weight gain, which add to their entire body image and profile. And here you clearly show that during 3 months, again, there is a drop in the Beck's depression score, as well as state and trait anxiety scale, where there is a very significant reduction even in the young adults who are practicing. So if you look at mood following the practice of yoga, you can clearly see the pre-post changes, the positive mood states of happiness, relaxation, optimism, confidence, a sense of contentment have increased from the scales of 2 to nearly 3 or more. And the negative mood states, being feeling stressed, feeling sad, frustrated, depressed, angry, pessimistic, all these mood states have nearly reduced by half. This was done in the University of California, Los Angeles, clearly showing that, these were not the groups who were essentially thinking of yoga as a typical Indian would do, that it's our ancient science, it should work. They are very objectively assessing it, and this is what they see. So now, if in this brief time, I've tried to show that there is a link between PCOS and stress, and then how one perceives stress, and the yogic practices reduce stress. Now, the next question is, what yoga are you talking about? Because today, at least in India, every second person has had some exposure to yoga. Either they have done it, or they have heard of it, or they're planning to do it, or they know somebody who is doing it. And if you talk to 10 different people, each one of them has their own perception about yoga, like you have a perception of stress. Somebody would say, it is sitting quietly and meditating. Somebody will say it is doing Surya Namaskar cycle. Somebody will say it's doing posture. Somebody will say it's pranayam. So, well, actually, all these are components of yoga. And these are, what you have experienced and benefit, you believe that is yoga. It's like the blind mind describing an elephant. So if you touch the trunk, you think that is an elephant. And if you touch the tail, you feel that is an elephant. But in reality, yoga encompasses all. However, of the various aspects of yoga, because here we are talking that the mental state is such. So how do you get them to do it? So if you tell them, it may not really be motivational. So we have one aspect of yoga, which is the practice of yogasanas. Now, in this case, you can get the person to do it, and then the changes start happening. So you say, okay, the only effort you have to take is come to the yoga class. And once in the yoga class, you put them in the various asanas or the postures. And once they are there, the effect starts coming in. And if they feel good, they want to continue it. So what are the practices that we use? And also, being a very ancient subject, there are various traditions. So depending on what one has studied, it goes down in a classical Guru Shishya Parampara. It's a lineage form where every tradition has set up their own standards and according to which they work. So what I'm talking about would be the tradition of Yogacharya B.K. Iyengar. Now, just to get a connect between the body positioning and the state of the mind. Now, we rarely ever observe how we sit. We are sitting all the time, most of the time. We are never really conscious of how we sit. Now, if you want to study the body-mind connection, you will realize that if a person is depressed, you will always find them sitting with drooping shoulders and a sunken chest. That's a classical description of anybody who has had depression. You read fiction, you read a novel, that's how. And if you are very anxious, you are stressed, you are thinking about something, you'll be sitting with your head on your palms, thinking with a very active frontal brain. So we try to modify the state of the mind using the body as a means, because the state of the mind is reflected in the body. So if we change the state of the body, you can change the state of the mind. And going back in time, I'm sure most of us remember in our childhoods when you were asked by parents or grandparents to sit straight and study. Don't lie down on the bed and study, because there's a lot of emphasis given to the spine. So you sit erect, the mind is alert. Mind is alert, you absorb better. And this connection is also connected with the breath. So basically the body, mind and breath from a triumvirate. So now in this particular case, if somebody has a breathing is very shallow, then one is anxious. So when you are very stressed, you breathe, your breath is short, you sort of use a term, I have butterflies in my stomach, you have a lot of fear coming in, which comes in, and the breathing is very shallow. However, when you're very calm, the breathing becomes very prolonged and soft. Now, you can modify it on your own, or you can even go into a yogic posture and modify it. So, for example, if one is standing and the moment you move your shoulders, corners of the shoulders back, broaden the chest, allow your eyes to drift towards the back of the skull, a state of quietness ensues. So, we use these kind of experiential sciences to bring this kind of a state. So, in the practice of an asana, when you put a person in a particular position, all these three start getting interlinked to give that state of mind which is desired, which is from a distressed state to a de-stressed state. So generally, we have various yogic postures. And mind you, here I have shown them independently, but these can be done with a support. So if a person is stiff, it doesn't matter. You have a stool at home, you have a dining table, so you can just rest your forehead. That gives calmness to the mind. So these, wherever the head goes lower than the chest region, it helps to immediately alleviate the sense of tension that pursues. The studies that I have shared have used a set of various asanas, and that is the one. So it is not just a single asana that works. It is a group of asanas that are done in a particular sequence, one leading to the other. Of course, the inverted asanas are really a miracle, but anybody who sees it at the first time may get more stress looking at it. How do you expect me to stand on my head? But the fact is, a person can be trained to do it. And again, we use soft props and supports to do it. So by the time they are trained to do independently, they do other things and it helps. And today, with millions of people practicing, it is easier to train somebody to do things if they're already into the subject. Again, we use, like I said, I talked about the connection between butterflies in my stomach is the analogy I used. So you can use supports. So where the abdomen gets extended, the abdomen quietens down, the mind quietens down. So I'm just giving you a few examples. Obviously, it's not a subject which can be taught in a span of 10, 15 minutes, but to give a clue on the methodologies that are used in the practice of yoga to give this kind. And then we also have these supine asanas. So again, you don't need this props or wooden things. People have a bed. One can slide down the bed, put some pillows down. So here, as it is shown, you can use these instead of a bed, the prop, you can be on a bed or a sofa, lie down, and then have something under the shoulders to get this relaxed state of mind. Especially this particular asana, which is called the Baddha Konasana, is an extremely popular asana, especially amongst women, because it gives much more relaxation in a span of 15 minutes as compared to lying down in bed for 2 to 3 hours, because the abdomen absolutely flattens and the person gets into a quiet state. And the good part is that anybody and everybody can be made to do it, provided they have a little will. Because if the mind is not willing, you can't force it. But even if there is a little will, then the pose transforms you to get more interested. However, I would like to say that there's a word of caution. In practice of yoga, you cannot have specific prescriptions. It will vary from an individual to individual, body to body. So you have a framework within which you work. So within that, you get people to do depending on what they are capable to do. And one has to understand that capacity, and it cannot be learned, and you need an experienced teacher. So especially here, when you're working with the body and mind of an individual, you can't have somebody who has learned it within a week or a month to start prescribing or making people do it. They have to be practitioners themselves, and then you will be able to transmit this knowledge to the others. So you actually need a teacher who can read your body. So otherwise, I would give an analogy that if you have everything extremely standardized, then even the medical profession, you don't need them. Let a robot do it. It doesn't work like that. So you have a doctor sitting in front of the patient, assessing the patient, and within the framework that is given, one works along it. So it is the same way with the practice of yoga. In fact, it is much more, because it's so very subjective. So one has to be very cautious. So with this, I end my session, just paying my gratitude to my Guru, Yogacharya Padma Bhushan P.K. Saingar, who actually not only got me into this subject and made me try to see if the scientific connections, if any, exist between them. So thank you so much. And thank you again, once again, Western UP chapter, for allowing us to share a variety of views, right from the myths to the yogic aspect and the very well explained lifestyle factors by D2. So over to you, and happy to hear any comments or inputs from the experts.
Yeah, thanks, Dr. Rajvi, for such an enlightening talk always. And always a pleasure to listen to you. So, Dr. Mridu, your expert comments for Dr. Rajvi, or anything you want to add?
Yeah, ma'am. Very nice talk, and thank you, the organizing team, for inviting me for this to chair the session. Really, yoga, we should feel lucky that it originated in India here itself, but we didn't know the importance unless until the Western people start doing and they do a research and then they project it. So it's a very nice, not only lifestyle management, yoga is also coming in every pattern of every managing every disease or every we can say every pattern of life. Also, the main three things which you told us, that is breathing, meditation, and maintaining posture. These are the three main aspects which we should practice. Right. Thanks a lot.
Thanks, Dr. Mridu. Dr. Anshu?
Madam Rajvi, we were fortunate enough to have you on this platform of Western UP chapter. I have heard you many a times, but this was a very special topic, and this is really near to my heart also. So we are very much enlightening by this top talk, and I really feel very high gratitude for you, ma'am. Thank you so much for being with us.
Hopefully, we'll be able to
and
give you a
sparing your
practical.
precious time with us.
No, I would be very happy to have a practical session, so where you actually experience it, because it's an experiential subject. So once you experience
Actually,
it, then you understand
yeah.
it.
This is very luring subject, but just this needs commitment, and the benefits are vast. I have myself experienced the benefits are vast, but still sometimes we break the cycle and then these benefits goes away. That is the problem. So perseverance is the must in the yogic science.
Yeah.
Dr. Anshu?
Yeah. Thank you for such a lovely talk, Dr. Rajvi. It was such a pleasure hearing you, and I think you have been trained by the Yogacharya, Mr. Iyengar. I think he was the best. What I know of, he was very strict, I believe. And I think in the context of PCOS, yoga is really can bring really good changes, because it tones up the body, it decreases the insulin levels, it decreases the testosterone levels as well. And if we could, if we could have an experience of it, that is what, that would be wonderful. And congratulations for such a wonderful talk. You talked about the basics. I love them. The head low position, that was really wonderful.
Thank you, Dr. Anshu, for your kind words. And any questions from the audience.
Shalini, we would like to
Yes.
have your special interest group with practical sessions, as Madam Rizvi is saying.
Yes, yes,
So we
sure.
will
Will.
do yoga with her. We love to have that session.
Yeah, the most
Yeah.
irritating thing,
Yeah,
most
so
questions.
after our Indian Fertility Society, this conference, we'll
Yes.
have somehow.
Okay.
Yes, ma'am.
Someday
Definitely.
We
we'll
can
have
plan
the
something. We can
sessions.
do something.
We will love to have it.
Yeah,
Yes,
Sure.
yeah. We'll surely have it after
Yeah.
this Fertivision.
In fact, we were wondering when Dr. Rajvi started this, we have been given a topic, what will we dwell upon? And when we kept digging in it, we got so many things to talk
Yes.
about.
Yeah. It's almost kind of a 2 years journey for all
Yeah.
three of us. And it's like every time we come up with the very new innovative ideas, Dr. Rajvi especially and Dr. Ritu equally contributing to it. So, the more we realize, okay, even this can be the holistic approach. It's not only the yoga, diet. Last webinar, we covered even stress for the doctors. So everybody was like, oh my God, this also could be a part of the holistic. Yeah.
We need
Madam, there has to be one workshop on yoga
Sure.
in our conference.
Dr.
There has to be
Rajvi
one
can do it.
workshop because
Dr.
teachers, we will learn, then we can only teach our patients and
Sure.
our girls and
True.
society at large. That will
Dr.
get benefit.
Unfortunately,
Rajvi is a
during conferences, it doesn't work out because
IFS
people have late
conference.
nights.
Yeah.
Yeah. So next year,
We have to lead by example.
Yeah. We can start with smaller meetings. Maybe that is a better option. So
Yeah.
where, the late night partying is not too long. But we
Hmm.
should surely do it because, once you experience it, then you are motivated for studies. And, like you rightly said, we wait for the Western world to tell us. So we can do much more in this field. So it's
Dr.
nice to
Rajvi,
be
you can
talking.
ask Dr. Sruveen to keep a session of yoga for you.
No, long back, Dr. KD had asked, but we tried it in one of the SRs, I think the Jodhpur one, and it was only Dr. Makwana, his wife, and Rahul, 3 people who were there. So
Okay.
generally, that doesn't work out because,
Yeah.
I mean, intentions are there, but people don't like
Time is not
Yeah,
good.
time is
Yeah.
not right.
Yeah, very true for such a big level conference.
Yeah.
No?
But
So
I would
with
be
this,
very happy to, if there is an interest to do something, I'll surely join you because we actually did a study with the doctors and we had a proper waitlisted control during the pandemic, measured the various stress, anxiety levels amongst MD doctors of various specialties. And we did find over a period of 3 months, we did online classes twice or thrice a week. And we found a substantial decrease in stress. And these were from government hospitals, Mumbai, KEM, Science, so, the actual teaching hospitals. And there was a massive reduction. So we would like to share it with the others because I think the stress levels among medical professionals themselves are so high. And then add on with all, like we discussed in the last webinar, about the various issues that the doctors are facing, right from...
Actually, stress is same. Our perception is different.
No, but when we discussed it in our last webinar, like you don't have violence against doctors. I mean, that is real, which is a big issue, I believe, in certain parts of the country. And we discussed about the administrative issues and, so it was quite an interesting webinar. So I think we can...
Yeah, true. Can someone take a picture? I don't think so. Himanshu is still there because he's busy with the
Maybe if
photo.
people around I can take one, but if people around, we can switch on the cameras. It will be better than the names.
Dr. Ruchika ma'am, you can take this screenshot.
Yeah, I'll just take a screenshot.
Dr. Ruchika ma'am, screenshot आपके कंप्यूटर में.
This view I have taken. I'll take a complete view.
Himanshu, are you there?
Yeah. Most of them have switched off their screen.
Yeah.
Okay, great. So Himanshu has taken it.
Okay, Shalini.
A lot of background.
Dr. Rajvi.
Yeah. Okay.
Hi,
So
Anshu,
sincere
Dr.
thanks
Shashi, Dr.
to
Ruchika.
the UP.
Thank you, ma'am.
Yeah.
Thank you, everyone.
Everybody, bye-bye. Thank
Bye.
you.
Yeah.
Bye.
Thanks, Dr. Shashiara, for such a warm approach.